popped up onto the market, but lots and lots of evidence that's come out with various different agents within the class. So always starting back in 2015 with EMPA-REG, which we now just quote at the tip of our tongue. All the residents know it. They may not know the details, but they know the name. And then moving on to the most recent sort of trials that came out this year, including EMPA-Kidney, which I'll mention briefly, as well as DELIVER, which is a key trial as well because it addressed and substantiated the evidence for heart failure management with SGLT2 inhibitors, and really sort of solidified the use of this medication outside of diabetes in the arena of heart failure, and that's translated into the CCS guidelines, which were just presented. And I know you have Kim Connolly later on this afternoon, and I'm sure he'll go over that. He talked about that extensively at Diabetes Canada last week. So to really not go over trials to death, I think, there's nothing audiences really puts people to sleep more than to go over all of the data in great depth. But I did want to sort of highlight that, it is good evidence. And good evidence means that you have, populations that's been studied over and over again using different medications within the same class. So we do believe that the effects of the SGLT2 inhibitors are a class effect, and then demonstrated in various degrees of diabetes for those trials that involved patients with diabetes, and for other trials with different degrees of heart failure. So really, what's emerging is that it doesn't matter if someone has a high A1C or a low A1C, you'll see benefit. It doesn't matter whether they have HFrEF or HFpEF, they'll benefit. And now it doesn't matter if they have mild or severe renal disease with albuminuria, without albuminuria, there seems to be benefit. Yes, the degrees of benefit are going to vary, and you do have to be cautious with different populations, especially using it in very fragile patients. But certainly, there seems to be a broad enough indication that you need to think about it, and you need to ask if you think that your patient should be on one of these medications because of the degree of benefit that we're seeing in all of these trials, and cardiac outcomes, CV death, hospitalization for heart failure, things that really matter to all of us as we work in the care of cardiac patients. So with regards to the newest trial that was just published in New England Journal this month, EMPA-Kidney was designed to really investigate whether empagliflozin reduces the risk of kidney disease progression or CV death in patients with CKD. And in this trial, it was a randomized controlled trial with EMPA versus placebo. And the outcome was looking at that combined primary endpoint. And I'm not a statistician, but you'll see a lot of this in some of these cardiac trials where it's not just one endpoint. They kind of pool together some primary endpoints. But hopefully with large enough of a result or sample size, they are able to tease out individualized benefits, even with regards to the primary benefit. And I'll demonstrate that. So in this particular population, what they're really looking for from a kidney heart endpoint is, if being on this type of medication, whether their kidney function loss was reduced. So think inverse. So there's always a gradual decline in renal function in patients who have pre-existing CKD, and that's certainly the case in patients with diabetes and CKD. But we were looking for a decline in that reduction or sustained CKD, sustained renal function for that population. And of course, prevention of going to those end-stage kidney outcomes, things like dialysis. So why is CKD important? Well, the risk factors for CKD are associated with all the risk factors that you see in your patients here at the Heart Institute. So, risk factors include dyslipidemia, older age, diabetes, hypertension, tobacco use, pre-existing CV disease, obesity, family history. These are really the same risk factors that we see for patients with coronary artery disease. So people who are at risk of one are at risk of the other. And then there's interplay between those two chronic conditions as well. What most of you probably know is that diabetes is the leading cause of end stage kidney disease. So, patients going on dialysis or needing transplant, the most common cause of that type of CKD is diabetes. But what might be surprising to some of you is that actually the majority of patients with pre-dialysis, pre-end stage CKD don't actually have diabetes. Okay, so this is important to note because again, when we're only looking at the subset of those patients who already have diabetes, already have end-stage CKD, we might be missing this bigger portion of the population who are at risk but have not gotten to that stage yet. Now, this is again just population epidemiological studies which show that having a reduced GFR and having increased albuminuria, those two things can be looked at separately, but also combined. Having the two together worsens outcomes, and they're independently associated with increased risk of CV death and kidney events in patients with type 2 diabetes. So, with every patient with diabetes, you need to be thinking about renal function, creatinine, GFR, but you also need to be thinking about the protein level in the urine because having the two together at a advanced state is very predictive of very bad outcomes. So the key inclusion and exclusion criteria in this trial, it really was anybody who had evidence of CKD, and you can see that there's two cutoffs for GFR. So you can have patients that have a very low GFR over 20, and it doesn't matter if they have protein level or not. So this is sort of that non-proteinuric CKD that gets included in the trial, and then you have a higher cutoff for those with a degree of microalbuminuria or frank proteinuria. And it really, there was nothing in the inclusion about diabetes, but certainly they structured a trial so that they did include a good portion of the participants to have diabetes. At least a third was what the inclusion criteria specified, and of course they should not have already been on an SGLT2 inhibitor. Okay. So here are some baseline characteristics. I'm not going to go over this in great detail. Again, data can be sometimes a bit boring, but what I wanted to highlight here is really, about 50% had known prior diabetes. In the cause of the kidney disease, about a third was diabetic kidney disease, and then 2/3 were other causes. Okay, so things like glomerular disease, hypertension, renal vascular. Again, something that you probably see a lot in this institution with renal vascular disease, and the mean GFR was 34, so not high, okay? And remember, they did include down to a GFR of 20, and that's important to note because that's a constant question that I get is, what is the cutoff? What can we use? When can we stop? And really, the evidence seems to suggest, at least from these trials, that you can go pretty low with the GFR. Maybe we can even go under 20, but the benefit is unknown at that point. This is the sort of the money slide, sort of the outcome. Okay, the primary composite. Remember, it's a composite outcome of CV death and kidney disease progression, as defined as a rapid decline in GFR or progression to needing end-stage renal disease treatments. And here, with that combined outcome, you can see red is placebo. The blue line is the group that was treated with EMPA. You can see a relative risk reduction of 28% in the group that was treated with empagliflozin. The trial was terminated early because of this very significant positive outcome that was statistically significant, and so it could have been even more separation of the curve had it gone on for the full duration of the trial, but certainly there was a significant outcome. And remember, when I say that you have large enough of a number and benefit, you can tease out, even within that composite outcome, where the benefit came from, and really the predominantly, at least at the point where the trial was terminated, that the majority of the benefit came from prevention of that kidney disease progression, without really an impact on CV death. Now you might wonder why. Okay, so we have other trials where SGLT2 inhibitors did demonstrate CV death benefit, particularly in cardiac patients who have had a prior cardiac event. So remember, this is a different population. So we're not talking about people who have had cardiac events, therefore are by default a little bit higher risk of developing a second cardiac event. So it probably may have shown benefit if it went on for longer, but certainly for what the trial was trying to demonstrate in terms of kidney outcomes, which we know is associated with the cardiac outcomes, it was a positive trial. There were some secondary outcomes that were demonstrated in the study as well. You know, the all-cause hospitalization was improved in the EMPA group, and that was statistically significant. So 24.8 versus 29.2, and that's important. Okay, so really keeping people out of hospital is always a good thing, especially these days. And then other secondary outcomes were not statistically significant. Think like the CV death, things like death from any cause, there was no significance. So the subgroup analysis, if you have a positive trial, you can then look at the subgroups and then make some sort of assumption about, which patients typically benefited more with the use of this agent. And it may not be a total surprise, but those with diabetes benefited more. It's a diabetes medication, and we know it has proven CV benefits in diabetes patients. So there was a trend towards more improvement in patients with diabetes. Certainly, there was really no great difference between the different cutoff levels of CKD, and really no great, difference in terms of cutoffs for albuminuria, except probably, the higher the albuminuria, maybe there was a trend towards a little bit more statistical benefit. I love this graph. I think of this graph in my head, and this is the cause of a lot of concern for a lot of people in terms of starting agents like SGLT2 inhibitors, because if you look at the blue line, patients who are on EMPA, you will see a dip in the GFR, okay? And it happens early. It happens at that 3-month mark, probably even at the 2-month mark, and then it levels out, and there's a crossover effect that happens around the 18-month mark. So the benefit is long term, and if you react too quickly to that initial dip in the GFR, you're going to take that benefit away from patients. So I was very cautious in the early days. I used to check GFR, at the 6-week mark, 8-week mark. I don't anymore. Like I usually do it at the 3-month, just like I would do with my regular blood work. I would do it again at 6 months. And only if there was a sustained decline, ongoing decline of greater than 20% at both the 3-month and 6-month would I consider that this might be that exceptional patient that is going to need to hold this medication. So I think this is reassuring. This is not the first time that we see this type of graph. It was certainly demonstrated in Credence as well with canagliflozin. So I think this is reassuring. So I think it's something to remind ourselves that, it's natural to see a bit of a dip. We see that with ACE inhibitors too, by the way. So the overall summary with this particular trial is that it was stopped because there was a positive effect on efficacy, and that empagliflozin did reduce CKD progression and or CV death by up to 28% in a broad range of patients with CKD, including those with and without type 2 diabetes, in the full spectrum of GFR, full spectrum of proteinuria, and it was irrespective of the cause of CKD, diabetes status, and across a broad range of GFR. So I think that, this trial is really, I think, going to change practice. It'll probably work itself, just like, all of the heart failure trials have worked themselves into guidelines. For the renal patients, where there was always a question, well, yeah, sure, for patients with diabetes and CKD, we're going to think about this. I think this might now be like, well, any CKD, we should be thinking about this class of medication. And certainly CKD and heart disease, CKD and heart failure, oh my goodness, you have lots of reasons to be thinking about this medication. On the flip side, I did say, as we introduce new therapies and widespread use, we need to be concerned about caution and side effects. And this is a little study that I did with one of my residents where we looked at SGLT2 inhibitor associated acidosis in the inpatient setting. It's still ongoing. We presented this at Diabetes Canada last week, and we're still collecting some one-year data that we hope to present and publish in a future date. So across all of the many trials that I've shown you so far, the side effect profile with SGLT2 inhibitors are actually quite low. The known side effects I think we all hear about with patients are the genital urinary infections, particularly in women who have a prior history of genital yeast infections. But really, though, that's manageable. You know, you get symptoms, you treat it, it goes away. If it keeps coming back, consider trying a lower dose, switching to something else, cranberry tablets, all sorts of different things that people try, and sometimes it works and sometimes it doesn't. DKA is the most significant side effect that we worry about, and what's worked itself into the literature is this concept of euglycemic DKA that's associated with this class of medication. I don't really like the term euglycemic because it assumes that this blood sugar is always normal. What is normal, right? So it really is just SGLT2 associated DKA. Now, why does that happen? Okay, sorry, I thought I was jumping to the pathophys slide. So why it happens is that this medication promotes glucose loss. So even though you can get ketoacidosis associated with the medication, you might get an inappropriate loss of sugar as well, so that the blood sugar doesn't look as high as it otherwise would in someone with classic DKA because they have type 1 diabetes and they omitted insulin. Usually you see a high sugar, high ketones, clear history is I did not take my insulin. I thought I was sick and vomiting, so I didn't need my insulin. That's a classic history that we hear with DKA, or they came in with an MI and they're unconscious and they go into DKA. But with this class of medication, because of that ongoing loss of sugar, you might see sort of a not too bad blood sugar, but then clearly they're sick, they're unwell. You check their, anion gap is increased. You check their blood sugar, it's not too bad, but you measure ketones and it's elevated. So across the different trials that were done in inpatient population, okay, so this is where we wanted to focus because outpatient, we have sick day management, we teach patients what to look out for, but is it dangerous to use it on an inpatient setting? So we do have some studies which introduce these medications on an inpatient setting. And again, the ketoacidosis level was really low, okay? Like there was none in Impulse and only 0.7%, compared to 0.3. So not really even statistically significant in Soloist, which was an inpatient study as well. So if you look at the trials, it's not really a big risk. So why worry about it? Well, we worry about it because we do see it. Okay, we see it a lot in hospital, and in fact, if I talk to my internal medicine residents, and I mention SGLT2, they're like, like this is what they see, right? They see patients in hospital with DK because of this medication. So pathophysiology, always good to kind of review. So what happens at the kidney level is you get sugar loss, but you probably get a bit of bicarb loss as well at the kidney. So that promotes this metabolic acidosis picture. And because SGLT2 inhibitors, they work on increasing hepatic production of ketones through a variety of mechanisms, inhibition of glucagon, increased breakdown of adipose tissue, which makes fatty acids, which then feeds into that, remember the Krebs cycle? It feeds into that, making ketones. So as an agent itself, it does promote ketoacidosis. If we measure ketones in patients who are on SGLT2 inhibitors, they're probably baseline a little bit high, but that doesn't mean everybody is a DKA, right? So again, everything is relative. And once you throw out that homeostasis where people are a little bit ketotic, now add a fast, they stop eating. Now add an illness, which promotes counter-regulatory hormone production and increase, liver output, then you're going to get that DK situation. And that's what we see in hospital. We see people who come in, who are fasting, for whatever reason, they're sick, they're waiting for a procedure, they're waiting for surgery, they have an infection, their cortisols are through the roof, that's where you get that problem of DKA. So this is what we did. I mean, again, it's still ongoing, but we really try to gather all of the data that we had when we started having these agents on formulary in hospital. Okay, so we looked at 2 sets of time. 6-month period initially. Now we're extending it to a year, between January to June 2020 and January to June 2021. So the 2020 data is when it wasn't on formulary in hospital. So there was no way someone could be on SGLT2 inhibitors in hospital unless they were taking their own. And then compare that to when it was on formulary. And we were certainly encouraging people to prescribe it, okay, based on the evidence that it's good for the heart, good for the kidney. So when we look at the 2 sets of data, you can see, and I've highlighted the star at the top with the Heart Institute, before it was on formulary, there was 0 cases of SGLT2 associated ketoacidosis at the Heart Institute. Post introduction on the formulary, we do have this huge increase, and we're not seeing that necessarily at that discrepancy at the other sites. Again, why is that? Probably because we're using it more here. Okay, I know the numbers look small, but as a proportion of the amount of patients that's admitted at the Heart Institute compared to TOH, it's a larger portion that are probably being prescribed this medication. Cardiology is the admitting service that we're seeing that in that discrepancy. And then when we look at what people came in with, those people that develop in hospital DKA, what were they admitted with? Infection was the most common cause, okay? And you see that is a common admitting diagnosis. And so certainly, more so than some of the other ones down here, heart failure, for instance, was not the admitting diagnosis. Some of the issues that might have contributed that we identified in the chart review. So infection, again, whether they were admitted with it or they developed it in hospital. AKI, so people do get AKI for a variety of reasons, i.e. they had a cath and they developed AKI after. Surgery was another big one. So those are the sort of the things that I want to highlight, and I want you all to be on the lookout for. If you see patients on these medications and you see that, they didn't come in with an infection, but now they developed an infection, they have an AKI, there's a planned procedure or surgery, you need to alert somebody. So the key points from our study thus far is that it's a great class of medication. It's been shown to significantly improve cardiorenal benefits in patients with and without diabetes. However, the SGLT2 inhibitors are associated with harm sometimes in hospital, including risk of DKA. And patients who are admitted in hospital, you should evaluate them for those risk factors. I didn't come up with that little acronym. The credit goes to Dr. Beanlands, who, after I presented a talk at Cardiology Rounds last month, he said, why don't we just call it Flickr? Okay, so things that you need to be on the lookout for: fasting, Lasix or diuretics, infection, cardiac surgery, renal function deterioration. So again, nice little acronym. He'll probably trademark it, so let him take the credit. I'm happy that cardiologists are very involved. Shifting gears a little bit to my sort of other take home from some of the the recent conferences. What's new on the horizon? Okay, so I didn't talk too much about GLP-1 receptor agonists yet. I think the studies with GLP-1 receptor agonists are not as uniform as what we see with the SGLT2 inhibitors. There's certainly ones that have shown tremendous even renal benefit, including semaglutide and liraglutide and dulaglutide. But there's been others where it's been more neutral. But what I wanted to focus on is what's new on the horizon is a new type of incretin, which is this dual GIP/GLP-1 receptor agonist. Tirzepatide is the name. It's already available in the States. It's not been approved by Health Canada yet, but it's on its way here, I suspect. And what this particular molecule does is that it is still a gut peptide, but it's a combination of not just GLP-1, but also the second peptide called GIP, which we all have. We all have both GLP-1 and GIP, but traditionally the previous agents have only utilized GLP-1. Now you have this dual peptide therapy, so it targets more sites, I guess. Okay, and it has a really long half-life, so 5 days. So it's a once a week medication, and it has been shown to improve diabetes, A1C lowering, as well as some other benefits. So it is different in the sense that it has potentially a different site of action or an additional site of action. So the studies with tirzepatide is called the SURPASS program. They've been going on for many, many years. You don't have to know the different SURPASSes. It's not on that test that Kim is giving you, I don't think. But I'll focus on 1 and 2. So you can see SURPASS 1 is monotherapy, which is use of this medication versus placebo. And 2 is versus semaglutide, which is our readily available once a week GLP-1 receptor agonist that we're currently using quite routinely. So the studies with SURPASS, they focused on different dosages, so 5, 10, and 15 milligrams, and evaluated for efficacy and safety at 40 weeks or 52 weeks. And this is sort of the side-by-side, very busy, basically highlighting the effect on A1C. So remember, I wanted to focus on the first two, SURPASS 1 and SURPASS 2. So with SURPASS 1, which is versus placebo, you can see, the darker the bars, the higher the dose of tirzepatide. But even at the lowest dose, 1.8% reduction in A1C. That's amazing. Okay, like that's really, really amazing. And then certainly as you go up in the higher dose, you get a greater A1C reduction. SURPASS 2 is versus sema. So the gray bar is semaglutide at the 1 milligram, which is the maximal diabetes dose. Keep in mind that obesity dosing with semaglutide is higher than that. So that wasn't evaluated in these studies. And you can see again, like compared to 1 milligram of semaglutide, you actually see superior A1C lowering even with the lowest dose of tirzepatide. Very exciting. Anything that we can use once a week and not use anything else, very exciting. So then obviously the other benefit of this class of medication is on weight. I'm sure you've all heard about the semaglutide shortage in the US because people are using it inappropriately for weight loss, rather than for diabetes or for true obesity. So this medication has that same potential of having that type of usage because the weight loss is pretty remarkable. So again, with the monotherapy versus placebo, you can see about at the highest dose 11% reduction in body weight compared to semaglutide at the 1 milligram dose. Remember, this is not the obesity dosing of semaglutide, which is higher than that. So, at the 1 milligram dose, you see, again, a significant additional benefit with the highest dose of tirzepatide. And really, even at the low dose, you see a very significant reduction in weight. 3 and 4 are just, with people who are versus insulin, people already on insulin. The one with insulin, not surprising, you gain weight with insulin, you lose weight with everything else. And then here, people already on insulin, you still see a pretty significant weight loss. So I think that's pretty remarkable because we have a lot of people who are on insulin interested in losing weight. So this is just to show there were no real big side effects, okay? And the things that people worry about and patients will worry about with this whole class, including GLP-1s, is it going to cause some sort of cancer? Am I going to get pancreatic cancer? The cholelithiasis, which was reported with liraglutide, it really was not significant in the SURPASS trials. The big side effect, though, that everybody gets, to some degree, some people worse than others, and lots of people have to stop it, is nausea and other GI side effects. And this is not surprising. The higher the dose, the more the side effects, okay? And then compare that to SEMA 1 on the bottom. So you can see if I kind of step back and look, like SEMA 1, pretty similar to tirzepatide at the lowest dose. So I have very few patients who can tolerate semaglutide 1. Okay, so I think that's going to be a big barrier to use, is really getting people even on high doses of a semaglutide or introducing this agent when it comes out because of the risk of nausea that you get with that. Now, I don't know about titration because certainly we find in clinic that really teaching people to titrate very slowly, eating differently tends to help. So it'll be interesting based on our experience, little tricks that we can try to help people tolerate these medications. So the summary of these SURPASS trials is that there is proven efficacy of tirzepatide with type 2 diabetes with significant A1C lowering higher than we've seen with any other diabetes medications. 97% achieve A1C of less than 7%. And a significant weight loss of 6 to 13 kilograms. It seems to be safe and well tolerated with obviously the GI side effects. We do still need the CV outcome trials with these medications before I routinely for CAD, CV patients choose it over other agents that have proven CV benefit, but I'm sure that's coming. Finally, in the last few minutes before I open up to discussion and questions, I think it's really time to celebrate our 10 years. We've done a lot in this building in terms of education, identification of patients with diabetes, involving stakeholders, collaboration, really trying to make diabetes management as part of our routine care here. And since I'm a diabetologist, I always say I have a diabetic-centric view of things. So diabetes is at the center, even though I know you guys care about the heart and all these other organs. But for me, diabetes is at the center. And when I try to put all of these programs down on a slide, I think about diabetes. I think about the various places that I see and manage diabetes. And this is what I came up with. So, we have our inpatient cardiology units, which have just really taken hold of all of the initiatives from the get-go. Really, like they wanted to identify their patients have diabetes. They wanted to have a pathway where they could be managed both on the inpatient and outpatient level. Cardiac surgery, they were not far behind. Once they realized, hey, taking care of diabetes actually helps us with our infection rates. So they were quick to really, again, embrace a lot of the initiatives that's been set forward, including preoperatively. So the whole prehab program, from what I hear is really, status quo now, really getting people optimized before surgery, and then involvement of good sugar management intraoperatively, which, to be honest, there's a fair bit of evidence for, but translating that into practicalities of how we do it from a CSICU transfer to the floor perspective, that took a bit of thinking and convincing, and Christina and Kim, being like hands-on on the ground, doing the education, doing the patient care. I think that's what really pushed things along, and there's still work to be done there, of course. And then throughout all of this, outpatient, having a dedicated diabetes clinic at the Heart Institute has been, career changing for me. I've been here every week virtually for a lot of the last 2 years, to be honest. But I've been here, for the last 10 years, seeing patients, collaborating with other physicians, and that's really, put diabetes at the forefront of what we do. And then hospital-wide, really, really thinking beyond just what we're doing and, having ways that we give insulin in hospital, using the insulin pens, the diabetes champions that I know that Kim has this wonderful team of champions that work with her to really make sure that, that she's not the only one kind of selling the message and everybody is involved. We talked about monitoring for complications. This is important. It's not all rosy and good. We have to always sit back, reflect, see the changes, evaluate for safety. Developing medical directives, screening, pre-diabetes. So, we wrote a little paper on really as we were screening for diabetes, we've picked up a lot of pre-diabetes. Does that mean anything? Should we do anything? We do send them out for education. Is that an impact? Did that change admission rates? So these are all sort of initiatives that's come out of all of this. And again, it's going to take me the rest of my career to continue to further this along with help, of course. So just thank you, all of you, for being involved, and this has been a real good ride. So the summaries and lessons learned. So I can say that, I definitely believe, and my message to other institutions is that comprehensive diabetes care in a tertiary care cardiac institution is achievable, it's effective, and that it really needs to be a hybrid of not just automated stuff, like we have automated order sets, we have automated directives, but there needs to be individualized care as well. And that's where identifying those people that would benefit from the individualized care and then intervening early is the way to go. And then with every quality initiative, there needs to be a safety and efficacy evaluation, refinement. We will be doing that with all of our order sets as well, to really make sure that we don't just come up with one idea and then not change it or modify it based on feedback. Collaboration is key. And then the further areas that I think is very exciting to explore, pre-diabetes I mentioned, because that's, for every person that has diabetes, another two has pre-diabetes, okay? So keep the stats in mind. That's a big, big bite of the apple to take. But, prevention has to start early. Obesity, the studies that I've shown with other new agents that could be helpful for obesity, we need to utilize that and other strategies because that is an epidemic, that is a risk factor for a lot of the things that we see, CAD and CKD. And nutrition. Okay, so nutrition, I think that's an untapped territory. It's always easy to talk about, eat healthy. What does that mean? Where's the evidence? What should we be advising? And looking into that further with specific populations, individualizing that a little bit. So that's my summary for 10 years. But, I really wanted to say thank you. Special thanks to the team that works with me. We're all female team, but man, we do good work. So, so thank you very much. And if there's any questions, I'd be happy to take them.
Any questions in the chat? A couple.
Have a question, Kim?
I do.
Okay.
Because I want to hear about diabetes remission.
Diabetes remission. Yeah. So
when we're talking about pre-diabetes around here.
Yeah. So diabetes remission is possible. So we've known that that's possible, and what patients want to hear is that intensive lifestyle modification will lead to diabetes remission, and that is possible, but that's rare. Okay, so the data indicate that you need a lot of resources, like one-on-one personal trainer type of resources, to really get somebody out of diabetes. And it probably has to be very early diabetes, like at that pre-diabetes stage, not many years into the diagnosis, pancreas is still working. And you can't achieve that. And we see that. We know everybody has a patient or two, or in my case, maybe 100. I don't know. It's who have been able to do that. And but then sustainability is the issue, right? So the long-term data is lacking. People who do achieve remission, do they stay in remission? For every patient that you think of that did achieve remission, you probably can think of another couple that came back in hospital 10 years later and their A1C is 12% and they just thought they were cured, right? So the most recent studies have focused on intensive medical therapy for diabetes, including agents like GLP-1 or insulin, okay, to try to treat diabetes like a cancer. You know, with cancer, you have like a little something that's precancerous, you don't leave it, you take it out, okay? Because you don't want it to give it years to develop as something, right? So the theory behind that is if you have early diabetes, treat it aggressively with the best agents you have, spare your pancreas with insulin, use medications like incretins that have, at least in animal models, seem to preserve beta cell function, and then perhaps, you can stop those agents and then be in long-term remission. We don't have the final consensus on what that would look like, but I think that's definitely a possibility.
Thank you so much. I love hearing you talk every time.
Oh, thank you.
And I always learn so much. So it was actually, and thanks to your last talk, I think at the cardiology rounds on
Yes.
the 10 years,
Yes.
Kim and I started a QI project where I now check for HbA1c in our amyloid clinic.
Okay.
And truthfully, we see a lot of pre-diabetes. So I'm just wondering if you could speak a little bit more to what we should be doing, because I generally just leave it to the family doctors to follow up with. But if there's
Yeah.
anything more we can do, that'd be great.
So to be honest, I think there's a danger to that for sure. Okay. I think what we're hearing from primary care is that number one, a lot of physicians already are not treating early diabetes. For them to actually now be relied upon to act on pre-diabetes when there is no clear guidelines or evidence for that is really leaving patients who are at risk to chance. Really, that's the way I look at it. Okay, so I think the minimum that needs to be done in a pre-diabetes population is they need to be referred for structured education, and I know that we do that at least with the inpatient at the Heart Institute. They all get referred for classes in the community, even when they're diagnosed at the pre-diabetes stage. In the ambulatory setting, I don't think that's been done as systematically. I think that's the minimum. Okay, so people need to at least be aware that this is a risk factor. There's a 50% lifetime risk that they will develop diabetes. They need to act on it now before it gets to that level. And there's benefit to do that early. And then there's treatments that you and your team may decide to initiate that have been substantiated in pre-diabetes. So things like metformin. Okay, so that clear evidence that in pre-diabetes, if you start metformin, it prevents the onset of diabetes. And I'm not just saying, start it and then you'll stay on it forever. The studies show that if you start it and you stop it, you actually don't progress. Okay, so that would be something to consider for the right patient. Yeah.
Can tirzepatide be prescribed if a patient has high triglyceride levels?
So it was not an exclusion in the trials with tirzepatide. So I think as an absolute, there's no worry to prescribe it in that patient population. However, the only caveat to that is, if someone has high triglyceride, has active pancreatitis, I think there needs to be caution with this entire class of medications with people who have chronic pancreatitis, acute on chronic pancreatitis, have a very high triglyceride level, and generally it's over 10 to be at risk of pancreatitis. You really probably should lower the triglycerides first.
Another question, for patients with type 2 diabetes, would you try to maximize metformin to achieve HbA1c less than 6?
So the answer is depends. So it's not uniform that everybody. So for patients who have type 2 diabetes and they're there is room for me to add on medications that benefit their comorbidities, I would aim to try to get the A1C as low as safely achievable. So I'll give you an example. Our first line still says that people with any diabetes still needs to be on metformin, and sometimes they're on very low doses of metformin. But this person just had you know heart failure admission, and I really, really want to start an SGLT2 inhibitor. It's not going to stop me to start it in that patient, even if their A1C is already at 6.0. Right. So I don't look at the A1C as an absolute no, I cannot add on something else. But in someone who doesn't have heart failure, who has no CAD, I may not want the A1C to be lower than 6, because there's no benefit that's been demonstrated in the study so far.
Thank you, Dr. Arnaud. It was a very nice talk. I was wondering if you can just sort of give a brief summary. Like I work as a pharmacist in the inpatient setting, and we have basically different approaches to patients coming in, depending whether it's cardiac surgery, whether they're, different admissions coming in. And with respect to SGLT2, there's sort of different approaches depending on, whether they're coming for cardiac surgery. Heart failure team loves to keep it on. Some advice guidance that says when they get admitted to the hospital, hold it. So it's quite variable. What would you recommend, like your approach?
So that's excellent. And actually the CCS guidelines actually go into this now in very prescriptive detail, which is great. And I really hope you'll hear more about that today. For surgery, it's simple: 72 hours. No. Okay. Be prior to the surgery, and then do not start it after the surgery until they're out of that acute state. And for me, that's they're off IV insulin, they're, eating. Okay. Those are probably my two big, criteria before I would even consider restarting that. Okay. Patients who are coming in for heart failure, all of the heart failure studies, even the ones that use it on the inpatient setting, they're not using it as a diuretic. Okay. So people come in with acute heart failure, they're fluid overloaded, they have pulmonary edema, you're going to be diuresing. Okay. And as you're diuresing it, why have them on something that potentially can limit your renal ability to tolerate high dose diuretics? So as they're on that, potentially higher than normal diuretic dose, I think it's best to hold it. Okay. Someone with stable chronic heart failure that's coming in for a test, that's different. Keep them on their SGLT2. It's going to prevent heart failure. But someone coming in with acute heart failure, do the diuresis first. Once they're, on a maintenance dose of their diuretic, then you can reintroduce.
What comment I'd like to make is that commonly pre-procedure, sort of maybe hybrid types of surgery, TAVIs and whatnot, I find that the interventional cardiologists tend to want to use it as diabetic management rather than, figure out what the blood sugars are. It's just
Right.
do that pre-procedure and then so that's kind of an area that I always find
We
a little
struggle.
bit tricky.
Yeah. Yeah. I think as a diabetes management, it is a very poor modality to manage diabetes, especially in a stress or procedure setting. I think if someone is coming in just for a diagnostic procedure that is a day procedure in and out, that's fine. You don't want to rock the boat with what they're on for their diabetes medications too much, especially when the procedure is not likely to cause any degree of renal issues. But for anybody who's admitted for a couple of days, there are better ways to manage their diabetes. Put them on some insulin. Like that's the easiest thing to do in hospital.
Thank you so much.
All right.
Thank you so much.
Great.
So we'll take a break now. We're going to come back right at 10:15, please. Dr. Paul Poirier is up, and of course, he's not here with us from Montreal, but he'll be online all ready to go. So if everybody could be back in place by 10:15, and hopefully we might start a little bit early and have a draw. Thank you.
To have to log into the $50 chance of winning a prize. Oh. Freya Kelly.
Yay!
Diana Sells.
Woo! Oh, 2 in person. Great.
So we'll do one more after the post quiz has been posted. So that will open at 12. And if you can complete that, it will close at around 3:45 when we wrap up, and we'll do the final prize then. So for our next presentation, we have Emily and Julie. Emily Serrano is the advanced practice nurse for smoking cessation at the University of Ottawa Heart Institute, where she participates in patient care, research, and education for patients and healthcare providers. Emily received her Bachelor of Nursing degree from the University of Ottawa in 2014. She is currently undertaking her Master's of Nursing degree at the Charles Sturt University. In 2014, Emily began working at the Heart Institute in the cardiology unit on H5. She transitioned to smoking cessation in 2020, where her passion for research and education, patient care, outcomes, and health promotion grew. Emily became the advanced practice nurse for smoking cessation in 2021. She provides clinical expertise to the Ottawa Model for Smoking Cessation and manages the Quit Smoking program. She has made many improvements to the program, emphasizing initiatives that focus on patient education and quality of care, such as the launch of a weekly nicotine dependence webinar and patient feedback surveys. Julie is the care facilitator in the Division of Cardiac Prevention and Rehabilitation. Her work experience includes the post-operative cardiac surgery ward for 13 years, special ed care with LVAD insertion and heart transplant patients. She has been a diabetes champion since program inception at the University of Ottawa Heart Institute. Julie is passionate about patient education with a focus on transition from hospital to cardiovascular rehabilitation. She is currently involved with many quality initiatives to increase the enrollment of cardiac patients into cardiovascular rehabilitation programs, optimization of elective pre-surgery patients, and post-operative enhanced outcomes using the enhanced recovery after surgery guidelines. Welcome.
You, Elena? Okay, perfect.
Well, I'll let you get started, Julie.
Thank you, Emily. So thanks everyone for coming to our session today. I'll remove my mask so you can see me. So yeah, today I'm going to talk to you about what ERAS is, the Enhanced Recovery After Cardiac Surgery, and what it means for our patients. So all that to say, it is a multidisciplinary team approach. It's very teamwork collaboration focused. Our team consists of registered dietitian, social worker, occupational therapists, vocational therapists, nurses, physiotherapists, advanced practice nurses for diabetes, smoking cessation, and the surgical APN, and as well as our physicians, surgeons, anesthesiologists, and our pre-admission unit staff. So what exactly is ERAS? Well, it provides us evidence-based protocols for perioperative care. It optimizes patients' outcomes, healthcare delivery, efficiency, it's cost saving, and it's based on the principles of best practice. It standardizes our care, and it's to be consistent for our healthcare delivery to these patients. We get team feedback, and it's all patient-centered focused. And the main goal is to reduce complications and promote an early return to normal activities. So on this slide, you can see that ERAS has many components. We have preoperative, intraoperative, and postoperative. So my bread and butter is the pre-education and prehabilitation program. And we will also touch on a few of these other components throughout the presentation. So we have this unique opportunity in the prehabilitation phase to optimize patients before they come for their cardiac surgery. So while they're at home, we're able to deliver them education, resources, and screen them for any high risk issues that may need to be optimized before they come in for their surgery. As well, this is our program objectives. So we have the cardiac surgery prehab program that aims to optimize and screen all of these elective surgery patients to identify those who may be at risk for complications. So our goal is to decrease postoperative infection rates, improve their glycemic management and their understanding of glycemic control, decrease their post-op length of stay, improve their mobility, their smoking cessation, improve their satisfaction, improve their nutritional status, and optimize their after discharge care. So having a plan in place for when they are going to be going home, and decreasing the patient and the key learners' anxieties related to the upcoming cardiac surgery. So we also want to increase their enrollment into the cardiac surgery program, cardiac rehab program. So just to give you a little idea of what our prehab program process is, we have the patient who's selected for elective cardiac surgery. They're then given a case request, which the triage office will send out a preoperative package letting this patient know that they've been selected for elective surgery. This patient will receive a package that outlines education, video links, nutritional handouts, and basically provide them all the information to prepare them for their possible upcoming surgery. Once they meet and have that consult with their surgeon and decide to go through with the surgery, they're then put into this prehab depot, which I monitor, and I'm able to have these patients then put into what's called interactive voice response system, IVR. I'm going to say that frequently today. And so from there, the patient will receive either an email, phone call, or SMS message with all of these screening questions that were developed by the multidisciplinary team to screen these patients for possible risk factors that could prevent them from having better outcomes for their surgery. So the patients will receive this phone call or email within 24 hours after we've put them into this IVR depot. So what that entails is the screening questionnaires that were, again, all developed with a multidisciplinary team. So we screen for malnutrition. We screen for their diabetes control. We check to see if they have a discharge plan in place. We're checking to see if they have any significant mobility issues. For valve patients, we check to make sure that they've seen a dentist recently and have no concerns there. As well, we check to see if they've used any tobacco or cannabis. And we also do screening questions called a PHQ-2 and GAD that screens these patients to see if they have significant anxiety or depression. So from there, we also do a symptom screening question, and we're able to provide intervention when we do have flags in the system when we do the callback. As well, at baseline, we do a quality of life assessment, and the automated system also confirms, have you watched the video that was provided to you in that triage package that was sent in the mail? So we're really given this opportunity to optimize these patients by providing them all of these resources, and I'm going to go through a few of those right now. So the main one that we really encourage patients to watch with their loved ones is the webinar, which is a 5-part series. that was also developed by the multidisciplinary team. And it goes over all the aspects of smoking cessation, diabetes control, um, mobility. It goes through how to get in and out of bed properly without using your arms. So it's a 5-part series that we have the patients view with a caregiver or a loved one. And just provides them the opportunity to go back and look things over again to see if there's something they want to familiarize themselves with. And then also we have a once a week Q&A session that's offered by the advanced practice nurse for surgery, a physiotherapist, and the registered dietitian. So based on that educational information they're given, they're able to come to this session and ask questions to the experts if they have anything that they'd like to address. So we encourage caregivers and loved ones to attend that session as well. And they can go on our ottawaheart.ca calendar to access this, as well as the teleconference line where they can call in. So just to give you a program snapshot, before we had the IVR system in place, we did have prehab, but it meant that patients had to physically come here in person to meet with the multidisciplinary team. So we were getting about 300 people a year. Now with our advancements and due to COVID, we've gone to this electronic system, and having this available for patients, we're actually being able to deliver more effective and equitable care because we're capturing everyone that's for elective surgery. So we've had 1,180 people to date enroll in the program so far. So it's really wonderful that we're able to provide this education and deliver the best standards of care that we can. So some more program developments I'll just quickly go over is that we're able to identify patients who may have complex issues. Maybe they live far away, they could need a translator, significant mobility issues, as well as patients that perhaps have never used a glucometer before. We're able to identify these patients. I'm able to bring them in, provide them a glucometer, and teach them how to use it so they can start testing their sugars before they come for their surgery and bring those numbers to their pre-admission unit appointment. So it's been really wonderful. I've also had the opportunity to use some Freestyle Libre sensors on patients who were identified of having an HbA1c of 8% or more. We're able to get them hooked up onto one of those, and they're able to have their sugars monitored by the advanced practice nurse within that 4 to 8 week period before their surgery, and she can then do interventions. So we also screen all of these patients for pre-diabetes and diabetes and send an automatic referral to the education program within their region. So it's really a great opportunity to optimize these people before they come and have their surgery. Additionally, we've added a handout on nutrition into that triage package that's sent to all the patients that are coming for elective surgery. So we refer to that during our IVR callback as well. My colleague's going to talk to more of that in a little bit. This program's increased our communication between the surgeons and the PAU. We're able to organize visits and have members of the multidisciplinary team come together. For instance, I'll be able to do glucometer teaching during a PAU visit, or have the physiotherapist or the social worker talk to this person within a one-time visit if they have to come on site, rather than having them come here for multiple visits. So it's really wonderful, and the surgeons have been great in identifying people to us that they think may be more at high risk, so we can get involved right away. And in September, we implemented an every 2 weeks symptom screening call. So these patients, up until they have their surgery, are getting an automated call asking them if, since we last spoke with you, have you had any change in your symptoms? So this is great because we're able to call these people back, be a contact and touch point with them, so they don't feel like they're alone while they're waiting at home for this surgery. If they have any changes, we're able to perhaps escalate to the other care team members, their surgeons, the triage office, or even direct them to go seek medical attention if their symptoms are that worse. So it's been a great new development in the program. And also coming soon, we're going to be screening people for their alcohol consumption, which will be interesting. I think maybe we'll have more flags than usual. But it is really important, and my colleague's also going to highlight the ERAS guidelines for that. So all that to say, we have ongoing quality improvement projects to kind of dive deeper into each of these disciplines to find out whether or not we are really making an impact on these patients. And I will provide a little bit of data towards the end of the presentation just to show you where we're at. But it is all for patient satisfaction and improving their surgical outcomes. So I will ask my colleague Emily to come and talk to you about a few more components.
Oh, sure.
Yes.
So I just wanted to let you know that Dr. Poirier will be joining us at 11:30. We didn't forget him. We just lost him for a few minutes, but he'll be joining us at 11:30. Thank you.
Thank you, Kim. Thank you, Julie. So, as you know, my name is Emily, and I'm going to be talking about smoking cessation, alcohol cessation, as well as optimizing nutrition prior to surgery. So this slide here was taken directly from the Enhanced Recovery After Surgery Guidelines, which state that smoking and hazardous alcohol consumption should be stopped at least 4 weeks before elective surgery. Tobacco smoking and excessive alcohol consumption have been identified as lifestyle risk factors. Smoking and excessive alcohol intake can lead to lung, wound, bleeding, metabolic, and infection complications in surgery. We screen this. Oh, thank you. We screen this different ways. For smoking, we ask people, have you used any form of tobacco in the last 6 months? And in terms of nutritional screening, we ask, have you lost weight unintentionally in the last 6 months, as well as has your eating been less than usual over the last 2 weeks? In terms of smoking specific effects on surgical outcomes, we're looking at decreased wound healing and tissue repair. It increases the risk of breathing problems, infections, wound-related complications, and blood clots, which then in turn translates to longer hospital stays. So what are we doing about that? After Julie flags the patient based off of the IVR questions, the automated phone call, we get a referral in the quit smoking program for patients who've used any form of tobacco in the last 6 months. The patient is then enrolled in our quit smoking program and added to a modified clinic schedule, depending on how far out their surgery date is. If the surgery date is coming up very quickly and the patient is very motivated to quit smoking, we will try to see them once every week, once every 2 weeks at most. And with that, we also provide obviously the counseling necessary, and we prescribe nicotine replacement products and provide them with free samples to help with the cost of quitting and to increase the likelihood of them quitting. Then we see them again during their admission. So after their surgery, we see them, we assess smoking status there, and again, provide counseling and nicotine replacement products for nicotine withdrawal symptoms and craving management. And then we enroll them in a follow-up program after discharge. This program is done is an automated phone call that patients receive about once a month for 6 months, where they continue to receive counseling from the nurses, and they can also get a voucher for nicotine replacement products there as well. And that allows us to really follow them all along of their trajectories. We see them before surgery, we see them during their admission for surgery, and then we see them for 6 months after surgery. So next I'm going to touch on nutrition. Nutrition can help patients heal better after surgery, so it's very important. And all of these components interact with one another. Smoking impacts how insulin is absorbed, for example, for diabetes. Nutrition obviously has a big impact on diabetes. And so all of these things together, we can't just tackle one issue at a time. We really have to tackle them all together to really improve patient outcomes. So nutrition, it helps achieve early recovery, maintain organ function, reduce the stress response, and then it also reduces post-operative complications such as nausea, blood sugar control, it improves healing, decreases deep sternal wound infections, decreases hospital-acquired infections, as well as decreasing time on the ventilator. So very important. And this is from malnutrition. And the prevalence of malnutrition at admission is about 45% in acute care hospitals in Canada. 24 to 65% of patients undergoing surgery are at a nutritional risk. Malnutrition is a strong predictor of post-operative outcomes. So as you can see here, malnutrition has a very strong effect on morbidity, wound healing, infections, complications, as well as convalescence, which then in turn can increase mortality, increase the treatments needed, increase length of stay, which then in turn translates to cost, quality of life, and suffering. So what are we doing about this? So once the IVR nurse screens the patient for malnutrition with those two questions that I mentioned earlier, they recommend a high protein diet and a high protein oral nutritional supplement twice a day for 1 month before surgery. We also screen for the A1C, which Julie will touch on a bit more later, having the goal of less than 7% pre-op. And then in terms of post-op, so this is during the admission, we encourage early return to drinking and eating within 4 to 8 hours of surgery with a high protein nutritional supplement. For post-op day 1, a clear fluid diet, and again, the supplement if tolerated. Some patients can also tolerate solid foods post-op day 1. And then in terms of the post-surgical diet, we recommend a no added salt, high protein, high calorie diet with, again, that nutritional supplement. And then post-discharge, to again encourage healing, we encourage the patient to continue on a high protein diet and a high protein nutritional supplement for 1 month post-operatively if they were identified as a nutritional risk. Perfect, and I will pass it back to my colleague, Julie.
So diabetes and the prehab program. So basically, we're able to identify patients early on. Anyone with an HbA1c of 6% and above is offered an automatic referral to the diabetes education program within their region. We have that goal of trying to get their A1C below 7% before their surgery. And like I mentioned earlier, those that have an HbA1c of 8% or higher are automatically referred back to their own endocrinologist or nurse specialist that follows them in the community to try and optimize their glycemic control if they have one involved in their care. Otherwise, they're automatically referred to Kim Twyman, our advanced practice nurse for diabetes, to try and optimize and intervene on these patients. Sometimes when I'm going through our depot and seeing high HbA1cs of 11 or 12%, it's an automatic email and referral to Kim. So just having that multidisciplinary team approach and being able to communicate between the disciplines and kind of give her that heads up that this person's coming, if I have the surgery date ahead of time, has been really great. And like I mentioned, some of those patients that I'm able to get a sensor on even before they come for surgery is even better because Kim can intervene even earlier. So basically, the program's really great in identifying any patients who have poor glycemic control and offers them the opportunity to talk to the nurse and get some education prior to coming in for their surgery. Oh, my slide went a little too quick. Sorry. Oh, okay. The next point that I wanted to talk about is the exercise and physiotherapy component to ERAS. So the IVR nurse screening patients who may have significant mobility issues is able to call these patients back and kind of have a deeper dive into why they have these mobility issues, whether it's they just need to review the educational video, or if they're using a lot of gait aids such as canes and walkers. And we also ask that question, can you get out of a chair without using your arms? So if that is deemed significant mobility, we have a consult to our physiotherapist where they're able to either do a Zoom call with the patient or have them come in on site and do a prehab assessment. So she'll see this patient, she'll have them practice getting in and out of a bed, and provide an individualized exercise program for this patient to do in those 4 to 8 weeks that we're hoping to get this person optimized before their surgery. So it's really great. They can practice these things, refer back to the video. And we also know a huge component after their surgery is early mobilization. So ERAS tells us that having early mobilization for cardiac surgery patients improves their outcomes. It has positive effect on their physical capacity as well as their psychological recovery, and it decreases their post-op complications and reduces their length of stay in the hospital. So this is a guideline for you to see what our clinical pathway looks like for our post-op day 1 to 4 patients. Just gives you an idea of how many times they get up into the chair, how many meters they walk. And we also have a fast track for minimally invasive cardiac surgery patients as well, and it's been proven to be safe, feasible, and beneficial. And not to mention surgical site infections, which account for 20% of all hospital-acquired infections, and it can actually have a 2 to 11-fold increase risk of mortality in patients. So we know that having the ERAS recommendations, some of you may have noticed your patients will have what's called Bactroban ordered. It's the intranasal antibiotic that's applied twice a day. 5 days prior to their surgery. And if the person happens to be an emergent case, they will have that given to them post-op as well. We also have many protocols for clipping and prepping skin when antibiotics are delivered in a certain amount of time before the cut happens on the operating table. And as well, the post-op dressing removal is now within 48 hours. And daily washing of the incision to try and keep it dry and no drainage. So these have all been recommended and they're being implemented into our practice. And just to give you an idea, in July and September of 2020, we had 10.73% readmission rates for our cardiac surgery patients. Since implementing the IVR system, we have cut that in half, more than half, by 50% to 5.12%. And our surgical site incision, our surgical site infection rates have also decreased significantly from 7.7% to 4.53%. And this is based on 2021 data. Since then, we've actually implemented the virtual care monitoring program. And I know that these rates are even less since we've implemented this. And it's a wonderful program being able to give patients who are identified high risk for readmission or surgical site infections the opportunity to connect with these virtual technology, have a nurse available to them, show them pictures of their incision, monitor their weight, and have that connection. So we know that this is reducing readmission rates and surgical site infections. And of course, enrolling patients in cardiac rehab is also super important. So in your day-to-day care, making sure that patients know that cardiac rehab is also super important to enroll in after they've had their cardiac surgery, because we know that it can reduce their risk of having another cardiovascular event by 25%, reduce their readmission rates by 18%. It lays the groundwork to help them lead a more healthier lifestyle and helping them to be more successful in managing their risk factors. And we've significantly increased our enrollment rate since having automatic referrals to this program as well. And we have a variety of program options for these patients, whether it's virtual education, on-site. And so it's really been wonderful to have this available for patients. So in conclusion, the ERAS protocols decreases unnecessary variations. It improves quality, safety, and value for patients. It is a multidisciplinary team approach, and it's imperative for our success. So let's all keep working together. Thank you, everyone. If there's any questions?
There's a question in the chat. Where is this pre-op info that is collected stored on the chart?
So that is a great question. I guess with Epic, you would have to search our interactions with the patient. We label them as prehab whenever we have an interaction or encounter, I should say, in our electronic medical record system. So you will see that interaction with us labeled as prehab. So you have the ability in the top right-hand corner to search that specific word, and you'd be able to see any of the services that looked after the patient. You'll be able to see our call with the patient as well, who flagged for those responses. So you can see what exactly we addressed during that call, which referrals were made during that call. So yes, it is on the chart. You may just have to search for it.
Another question here is you mentioned excessive drinking. How much is considered excessive?
That's a great question also. So we are in the midst of developing our specific screening question for alcohol use disorder prior to having cardiac surgery. So it's in the works, but you'd have to refer to the Canadian guidelines for alcohol use. Obviously under 1 ounce of alcohol, I believe, for women and 2 for men. But this is kind of changing. There's new guidelines out, and so we're mindful of that. And that's why I kind of mentioned that the flagging in our screening may be a little bit more than we expect, because this question may be very broad, and patients may be a little thrown off by that. So that's why they're going to get our call back, and we'll go through the education with them once it's implemented.
If I can just add to that, thanks so much, Julie. We've formed a partnership with the Royal Ottawa, the RAM Clinic specifically. So they're really an amazing group, and that's their area of expertise. So we're not experts when it comes to addictions and substance use. So we're working with them to finalize our triage guidelines. But essentially, it's looking at patients who have a dependence, so people who would be struggling with not drinking for 4 weeks prior to surgery, people who would have symptoms, all those things. So very important to keep our patients safe. So we will be following a very strict protocol supporting these patients and really coordinating this with these community providers who are experts at supporting these patients.
Thanks, Bonnie.
Hey, Julie, that was great. And Emily, thank you guys so much for giving an overview. I love always hearing how great, all the great work you guys are working on. I did have 2 questions. The first one, and being very mindful of the statistics that women tend to enroll in rehab much lower than men, right? And being mindful that we are the house of the Women's Heart Health Center. I'm just curious, you pulled up some numbers of men versus women who are enrolled in your prehab program, and I don't know if that's reflective of more men are having surgery than women, and if not, if it's pretty 50-50, what work you guys are doing to try and increase your enrollment rate of females.
Well, all of our patients that are provided that conversation with the surgeon and put in for elective surgery are going to get put in the program regardless of their gender. So we capture everyone. So it's just a matter of who is coming in and being put on our list for elective surgery or not. And then we get their names and they will be put in the automatic voice response system. So I don't think there's necessarily a way to increase enrollment into it. It's more specific to, I guess, who's consulting and seeing which patients need to have surgery. So I can certainly send you how many men versus women. I mean, typically it's usually we have a lot more men having surgery, but yes, Bonnie. Rehab. Surgeons. Yeah.
And I don't have a cardiac surgery background, so I wouldn't know those numbers. And then my second question for you guys, just how great the program has been, and I'm mindful it is only, you know, a couple months into being. I'm just curious if you've been approached by other like surgical sites or the cancer center, and how sort of translatable this program, the prehab and the rehab, would be for those types of other patient populations.
Yeah, that's a great question because I know that we have been approached to have this prehab program enrolled in other sites. We do partner with Newfoundland patients currently, and we're working to develop that relationship as well. I'm sure Bonnie can speak to that. Um, if we do have like a toolkit that's in development if patients, or sorry, if sites do want to adapt this model.
Just have a question. I saw the high calorie, high protein diet and the dietary supplements. I don't think I have seen in the patient's chart that much, like most of them like still on the HI diet. So patients coming from CSICU, same diet, it haven't changed. And I don't think the more nurses know about they have to change the diet and the high protein, high calorie. This has been missing.
Yes, I hear you. And I think it has to do with our order sets that come over from the intensive care unit for sure. It is something that can be worked into and built into Epic. And it is, you know, something we're reinforcing. It could be a conversation with the registered dietitian just to make sure you are getting the patient on the proper diet. And these guidelines, you know, are fairly new to everyone. I mean, for myself too, we weren't doing this. I always never fed my post-op day ones because I did not want to deal with puke. So I have to say it was eye-opening for me too. Oh, I've got to start feeding my patient right away. But then once you see the ERAS guidelines, why we're doing it, how it can increase, you know, they need those calories to have the energy to do their walks and have their energy to do their deep breathing and coughing, and it helps with wound healing and getting them out faster. And we know actually based on data that we've decreased our length of stay by 1.24 days as well. So I think it's a matter of maybe just having a conversation with the educator and making sure that the clinical pathway is translating over to your ward patients and involving the registered dietitian. I'm happy to talk to Amy about that as well. I'm sure she regular diet just says regular, yeah. Well, that's why I'm here to inform you guys about prehab and what. Yes. Yeah, for sure. And it's exactly, if you didn't know, then that way you can bring this back to your team and say, hey, we should be giving people those Ensures and Glucernas after surgery if they can't tolerate those solids.
In the chat as well, the question is the dietitian involved in teaching the high protein diet or individual consultations?
So
Is it more the nurse?
So they are involved by having that Q&A session that I mentioned earlier, that there's a whole segment in that 5-part series as well that's sent out to all these patients in their pre-op package that goes through nutrition. Then they're given the opportunity and counseled at that live Q&A session as well. And then during our phone call, if they flag, we also give that same information. So that's when if we identify that there is a nutrition concern, we will have the registered dietitian connect with that person on a modified basis up until their surgery, and they're able to have one-on-one counseling with them.
I just wanted to stay on topic instead of straying off to something else. It's Kim. I just wanted to comment on the high protein, high calorie diet. So if the dietitians are involved and the patient's been identified as a high risk, over in CSICU, they're seen by the dietitian team, and on transition to the ward, they are on high protein, high calorie diets. So the people who are really sick, take a look. They are ordered because they really do impact people's blood sugar. So I've been
Yes.
seeing them for sure. So anybody who has been identified as a malnutrition risk is usually seen by the dietitian in CSICU, and then on transfer, that diet's been maintained.
Thanks, Kim.
Thank you. Hi, I'm Louise, and I guess I'm going to stay on the nutrition topic as well. Great presentation, guys. So I do the IVR for diabetes and talk to a lot of post-op patients. And then when I talked about their diet, like some of them will say, like I've got renal disease and I've been told not to take too much protein. So I guess, so what's your, like your key message with that? And, how much, should they be seen by the RD, or, do you have like a certain amount of protein that, like what's high,
So, I mean, I'm not
Thank you.
the expert in that department. So I would suggest if patients are really concerned about their post-operative diet, that they should maybe have a referral to the registered dietitian. Just because we just, based off the ERAS guidelines, want to have patients have that increased protein for just a month when they are identified as malnutrition or at risk. So I wouldn't speak to specific renal and all of that. That would be more the registered dietitian's plate.
Thanks, Julie. So Kim asked me just to come back up and use the mic, just because you can't hear back there. So just getting back to women and enrollment in cardiac rehabilitation, just speaking to that. So in our cardiac rehab program here at the Heart Institute, we've increased the enrollment of women by 9%. In the last 2 years. So really that's amazing. And it is in alignment with men. We're always going to have more men than women because we have more men coming into the Institute, right? But if you look at it from a proportional basis, it really is pretty much equal to men. So not to say that all the work has been done, it hasn't. We have to keep looking at the way we can individualize programs to meet the specific needs of women, and also the specific types of, diseases and cardiac kind of illnesses that women have that are a bit more unique to that patient population. Also, just in terms of the prehabilitation program, this program has been supported by Ontario Health, and certainly we are working with them to look at broadly moving the program also, to throughout the region and elsewhere, because it is an amazing program. The data that you demonstrated today is phenomenal. We only expect that to get even better. We're also going to be publishing a manuscript as well, sort of a how-to toolkit, so others can implement it. So great presentation, Julie and Emily. Thank you.
Thank you, Bonnie.
Okay. We have another question in the chat. This might be more for Emily. Would you address recreational use of cannabis?
I don't see the question. Oh, yeah. Would you address? Yes. So I do address recreational use of cannabis. Our motto is that any smoked inhaled into the lungs is not good for the lungs going into a cardiac surgery. We do know that cannabis increases heart rate and blood pressure, which we don't want. And cannabis can also interfere with a lot of medications, especially anesthetics and pain medication. So we really recommend that if the patient can, that they abstain from using cannabis before surgery and after surgery. Not that there's a lot of research on this, but we know that anything going into the lungs is not a good idea. And if it's a risk reduction and the person isn't willing or can't stop using cannabis, we may recommend edibles, but they follow Canada's lower risk guidelines for cannabis use.
The final question is for patients referred pre-op for diabetes education, do you note the surgery date? It could help the EP prioritize of hoping to get education prior to surgery. So currently there's quite a backlog with the community diabetes education program. It takes about 6 to 8 weeks, maybe a bit longer, just because there's such a big volume. They do triage them, so it could help to say that they are awaiting surgery, but overall they're just a very backlog system.
I will say that on all the referrals that we make, we do put a little blurb at the bottom. Please see this person for optimization. They're going for elective cardiac surgery. So we do try and put that there. But unfortunately, when we get the names and when their surgery happens, it's generally in the 6 to 8 week window. Sometimes it's longer, sometimes it's shorter. So we try our best. It's not a perfect system, but it's obviously proving to be super beneficial, and we have great feedback so far with patient satisfaction. So, yep, it's a great program. I'm all for it. It's me in business.
Okay, thanks, Julie and
Thank you.
Emily.
Want to do another draw? Sure, the final one, because we have some time. I'm not sure if Dr. Poirier is ready to go or not. We've got, you guys can't see the screen, but we've got.
I'm
Paul
there,
on here,
ready when you
in the
are.
background. At break, there are about 60 people online virtually with us, so.
Can you hear me? Hello?
Andrew do his work.
Yes. Oh, I do see.
Yes, we can hear you. They're just gonna do a little
So we'll do the
prize
final
here.
draw.
One sec.
Okay.
Oh, it's not our final draw. Rebecca King. I believe she's virtual today,
Is she? Okay, cool.
but we will get in
Keep her
touch with
name.
you.
Oh, there's Dr. Poirier. Maybe he's ready to
Yeah,
go.
maybe.
So just. Yeah. Dr. Poirier, can you hear me? Oh. Andrew,
Yeah.
is he ready to go? Did he say?
You ready when you are?
Oh. Are you good to go? Yeah, okay, good, awesome. Thumbs up. Resume here for sure.
All right, Dr.
So
Poirier.
Dr. Poirier is a
you're
graduate
good
of
to go.
Laval University, Quebec, Canada. He received his bachelor's degree in physical activity sciences and his master degree in experimental medicine, studying the role of exercise training in type 2 diabetes. He then went to medical school and obtained his MD degree in 1992 from Laval University. I just want to comment here. Years ago, I used to be introducing people that were older than me, and now it's the reverse. It's really tough. Sorry, on the side note there. Where did I leave off? Sorry. Laval University, where he subsequently completed specialty training in internal medicine and in cardiology from Laval University. Sorry. Lost my spot. Studying the role of exercise in diabetes and the impact of diabetes on exercise capacity. He pursued postdoctoral studies at the University of Colorado Health Sciences Center in Denver. in the endocrine division under the guidance of Dr. Robert Eckel. He is a professor of the Faculty of Pharmacy at Laval University and is playing an important role in researcher training, teaching students and residents, board certified cardiologist since for 20 years. He was recruited in 2000 for medical leadership of the cardiac prevention and rehab program at University Institute de Cardio. How's the French there, girl? You want to do that one?
L'Institut Universitaire de Cardiologie
C'est pas grave, c'est pas grave.
Pneumologie du Québec.
Forget about it.
Dr. Poirier has several research interests and has collaborated on a wide variety of basic science and clinical studies, clinical trials on local, national, and international trials. He's currently president of the Committee de Promotion en Profession Cardiovasculaire of the Association des Cardiologistes of Quebec. Dr. Poirier is an author or co-author of more than 500 scientific papers in peer-reviewed journals, 450 abstracts, 35 chapter books, and hundreds of presentations, most of which are in the area of exercise, risk factor management, obesity, diabetes, and cardiovascular disease. He's been chair of the Obesity Committee on the Council of Nutrition, Physical Activity, and Metabolism of the American Heart Association. He was part of the macrovascular subcommittee of the Canadian Diabetes Association for the Clinical Practice Guidelines back in 2008, 2013, and the most recent ones in 2018. He was involved in the recent Canadian lipid guidelines and in the recent Canadian obesity guidelines, which is why we have him here today. He plays a very active role in grant and manuscript review. Dr. Poirier has a long-term interest in exercise, obesity, diabetes, cardiovascular risk factors, and cardiomyopathy, and the role of weight loss and exercise in the management of these diseases. So I just wanted to welcome Dr. Poirier. I read, the reason why you're here is I read an awesome article on how he has incorporated obesity into cardiovascular management. So the article really spurred my interest. We've been working a lot here at the Heart Institute on on obesity. We've struck a committee and several subcommittees, trying to sort of change the milieu of, if you will, of the building and try and make our patients more comfortable and trying to have some conversations around obesity. So welcome, Dr. Poirier. Thank you.
Dr. Poirier, on your control bar, you can take control and you will have control of your slides, okay?
So where is that? I've got participant, conversation, reaction, order, share.
It
So
should be take control or request control in that menu bar.
yeah, okay. So I click on this.
Yep.
Is there something happening?
Yeah, you should see your controls. You should be good now.
Let's see. Okay, so I have to go like this and then, oh, we'll see how it goes. Let's see. Yeah, it doesn't, I have to click. Okay, that's, well, let's see here. Okay, good. Okay. Thank you very much. Thank you for having me. Thank you for the invitation. I'm sorry for the delay. I had some, the problem is usually 18 inches in front of the screen, so I'm the problem. So I'll try to keep it, quick so we can have a nice discussion at the end. So we're going to discuss the impact of obesity in today's cardiology. If you want to read about obesity and cardiovascular disease, we did I think, a nice review on a cardiovascular point of view of obesity from the HA. So we did present that last year, actually. It took us 18 months to produce that kind of paper, but, I think it's a nice paper for you to read. Can you hear me well? Just to make sure, can you hear me well? Can somebody react or do something or chat? Okay, good. Thank you. Okay, so people have changed. You were talking about smoking and smoking cessation. Now, when I train, I got that patient on the left, and now we got those patients on the right. So people have changed a little bit. The phenotype have changed a little bit. And you know what? when you see people that you've seen for the last 25 years, and they were kind of, chubby when you met them 25 years ago, and they're slim. You're kind of afraid of asking what happened, where is your cancer type of question, because they lose weight. It's like asking a pregnant woman if she's pregnant or not. You don't ask that kind of question, right? So obesity, we're more tolerated to see obesity patient because now it's the norm. So if you look at that slide here, you can see between 1980 and 2000, the decrease in coronary artery disease death in US. So 40%, 50, let's run it up. 50% of the death is by what we do in today's cardiologists. Very fancy treatment, very aggressive secondary treatment. But at the other end, the other half is explained 24% by cholesterol, 20% by systolic blood pressure, 12% by decreased smoking prevalence, 5% by decreasing physical inactivity. And now, nowadays we don't talk about physical activity. We talk about sedentary time. So now this is how low we get. We talk about sedentary time and we fight sedentary time. And if you look at the 8% increase in obesity and 10% increase in diabetes, some people think that we're going to lose everything that we gained for the last 20 years because people are getting more obese and got more diabetes. So that, obesity is a new risk factor. Is it that new? It's been published at the AHA 25 years ago also that obesity is a risk factor. I would say to you that it's not a risk factor. It's a risk marker. Because a risk, and people will say, he probably is French, probably he doesn't know what he talk about. But a risk factor needs three things. To become a risk marker to a risk factor, you need three things. You need first thing, make sense, pathophysiologically speaking. Second thing, the more obese or the more cholesterol, the more bad event or bad outcome that you got. But the third criteria is if I treat that risk factor in the randomized trial with whatever treatment you use, you decrease major adverse coronary cardiac outcome, right? So I don't have any data showing that if I treat obesity by diet, by exercise, or by bariatric surgery, or by drugs, I don't have any randomized trial showing better cardiovascular outcome. So we're waiting for that trial to be done. It's ongoing. We're doing a bariatric surgery trial with the McMaster people, and there's a pharmaceutical trial going on right now. We're going to have probably the results. It's like those little small cardiology trial. It's 18,000 people, separate, randomized, optimal care versus drugs. And it's in obese patient with coronary artery disease, and the data will be available next year. So this, if it's positive, this will change the game. So the thing is, while waiting for that trial, if you look at on the left, the smoking here, so we decreased the death by smoking by 0.9% during that 10 years. But here we increased by 2.6% the death by diet and physical inactivity. So if you look at the trends, the decrement in death by smoking is outweighed 3 times by the increased death by sedentary lifestyle and diet. So we need to change that path. And if you look at cardiovascular mortality in obesity, men and women, little study like in cardiology, about 300,000 people, non-smoker without cardiovascular disease. If you look at that, at 30 BMI, you increase in terms of cardiovascular mortality is obvious. And if you're lean or frail, you got increment also in cardiovascular mortality. If you look at the Enterhart study, BMI was not in that model, statistical model, a risk factor for myocardial infarction. But if you look at obesity, abdominal obesity, and if you look at the biggest tertile with the lowest tertile, then there was an increase in myocardial infarction in the pure data, not the pure, but the Enterhart data. And if you look at the country, here in China, the risk attributable to obesity as a risk factor for MI is only 5.5%. Why is that? Because it takes usually 20 to 25 years of obesity to develop clinically significant coronary artery disease. So China is moving from a cycling and sushi environment to a McDonald's and car environment with all the smoking going with that. So it takes time for an obese to get sick from coronary artery disease. So several organizations and guidelines report that benefit associated with a 5 to 10% weight loss uh, is good for your health. It's not me that's saying that, it's all the guidelines, and the Canadian guidelines say the same stuff. So if you lose 5 to 10%, you got very nice benefit from a diabetes point of view, from a blood pressure point of view. But the problem is there's no randomized trial showing that if you lose 5 to 10% weight loss, you increase survival. And all the drugs that been on the market before and had been, canned, have been, retrieved from the market, didn't show anything in terms of survival. So, according to the WHO organization in 2014, 1.9 billion adults are overweight, and it's 39% overweight and obese. So it's one of quarter of all the population of the world. And if you look the obesity in men and obesity in women, it increased tremendously through the years. And remember when you see a patient who is overweight and he lose weight, or when you're your friend, you don't say, "Oh, that's nice. You went into a diet, or you did exercise, you do something good for your health." You're just waiting to see if you've been sick or it's been COVID or anything like that. So if you look at the prevalence of obesity in United States, it's increased, for here it's been published last year or so. So it's been increasing through the years. And if you look in evolution of Canada, it's the same. So if I want to sell you something, I would say to you that severe obesity has increased 500 times, but the absolute number is not that high, right? This is the obese patient that fits the criteria for bariatric surgery. But here, the number is pretty huge. The obese patient with a BMI of over 30 kilogram per meter square, this is huge in terms of population. So it increased through the years and it's still increasing. And this is in US, the same slide that the one before. So severely obese patient increased 500 times, but class 1 obesity increased only 2,000 times, 200 times, but still the number of those patients is tremendously increased. So if you look at the current portrait of obesity in Canada, 1 out of 4 adults and 1 out of 10 young people are obese. And in the world, it's half, the population, a quarter of the population is overweight or obese. So what from our guidelines, and you should ask you that question. If you ask the weight of a woman, without winning her, okay? The woman will decrease their weight. You know, they will say, okay, I'm 140, 155, but in the real thing is usually a little bit heavier. And the guy don't they don't bother usually. So when you need to measure it because the reported weight the patient tell you is usually decrease in women and increase in men. So if you look at the economic burden of obesity, you look at here the direct cost and here the indirect cost. Okay, so it's about half. If you look at cardiovascular risk factor, it's there. But look at chronic back pain, how costly it is in terms of indirect costs from insurance company, from not being to be, they got sick leave from the work and all those, capacity to work and all those things. So if you look at that, this is pretty, it's 7 billion a year in Canada. And if you look at here in Quebec, you know, it's 1 billion. Okay, so you got the medication associated with comorbidity, associated with obesity and overweight. You got invalidity here. So invalidity of obesity, it's 6 million. No, 600 million, right? So this is really concerning because we need to know how to tackle better obesity because it's costly for everyone. The other thing is life expectancy and in obesity. So if you look at life expectancy in obesity, here you got on the left women and on the right men. And if you look at the age of 30 to 39, and you look at normal BMI to increase BMI, and you look at how many less year you got, but look at the number of healthy years, right? So if you look at that, the number of healthy years, you see when people retire, they're not healthy anymore. Okay. So if you're obese at 20 to 39 in women and 20 to 39 in men, the end of the end of life, the healthy years is really something we need to tackle as clinicians. And if you look at the associated comorbidity or condition, it's a no-brainer. You probably know this better than I. So it's increased sleep apnea, diabetes, hypertension, osteoarthritis, and all those things. You got the number there. And by the way, I send the slide to Kimberly. So if you want the slide, feel free to take those. It's all in English because I have to translate everything. So it's all in English. Use them. I don't have any copyright on those. It's free for you to use. And look at that one. This is BMI very high, and this is BMI, simple obesity. And look at the numbers of patients with comorbidities that are listed here. Diabetes, hypertension, dyslipidemia, sleep apnea, GI reflux, hypothyroidism, anxiety, depression, osteoarthritis, chronic pain. Look at how many chronic conditions are associated with patient. So patient suffer from a lot of conditions associated with their obesity. So how do you identify obesity? And how do you manage weight loss? First, BMI. But you know what? BMI is a crude marker. If I say that to you that my brother is 6'5" and he weighed 350 pounds, you would say, oh, yeah, he's probably obese. And I would say to you, he's playing football for the Rougiard. He's playing Western University this weekend. So you will change gears. So you need to see what kind of patient you are looking for. If you look at the frail, healthy patient without any muscle, with a big waistline, this patient is obese because his increased waistline is associated with a worse prognosis and a worse metabolism in terms of lipid, hypertension, glucose. And then you look at diabetes, you look at dyslipidemia, you look at lipid, how obesity and fat, lipo, um, influence your metabolism. So there's no condition, no specialty in the medicine today's that are not impacted by obesity. You can be the gynecologist, you can be a pneumologist, you can be a nephrologist, you can be a dermatologist. Obesity is impacting every field in medicine. So what's the definition of obesity? This is the old definition of obesity. BMI 35, excess weight, 30 obesity class 1, 35 obesity class 2, 40 obesity class 3. 15 years ago, we were at the HA talking about those very severely obese patients, right? And those patients in the bariatric surgery field, they say, if you got a BMI above 40, above 50, you're a super obese. And if you're above 60, you're super, super obese. We found that pretty discriminating. I, Mr. Smith, you're a super obese. What can I do for you today? So it's not a big science, but we just, add up some two classes, class 4 and class 5 for those super obese or super obese, super, super obese patient. That's into the Canadian guidelines now. What is obesity? So it's a BMI for those of you who are younger. In white, you got in meters and in kilos, and what who got some more experience in life. You got here in blue the weight in the height in feet and inches, and the weight in pounds. So this is BMI above 30. But if you look at that, those two have a BMI of 30. Okay, so if that guy is taking a lot of testosterone on the left, he's decreased HDL, increased TG, he's probably at cardiovascular risk. But if he's not, if he's not taking testosterone supplement, he's not at cardiovascular risk. But this one is at cardiovascular risk. So BMI per se is flawed, and there's no sex difference, and there's no age difference. Okay. The next indices that will probably become more easy to use in 5 to 10 years, I predict will be waist to height. Okay, waist raise to height ratio will probably fit best because it's ethnic independent, it's age independent, it's sex independent, and the threshold will be probably 0.5. But that's another issue. So if you look at waistline target, so 94 centimeters in men and 80 centimeters in women is the European Caucasian waistline target. And if you look at the US, it's 102 and 88 in women. So if you got a guy who's got 110 centimeters in the waistline, don't say to that guy, we need to reach 94. You will lose him. Okay, reach 102. But if you got a given patient who is at 98, right? And is obese from a waistline perspective, from a metabolic perspective, then you can say, no, it's not 102, it's 94. Okay, so this will be better for you to use in terms of target. So we all seen those kind of patients. Sorry, I smoke too much and I drink too much and I eat too much. This is our cardiology patient usually. We need to change the paradigm. If we talk about diet and exercise, patient think that you want to put it on a vegan diet and to run marathon below 3 hours and 30 minutes. It's not the case. So we need to readapt and reformulate our goal. Because the high-risk obesity phenotype is not an independent predictor of CV outcome. It's the driving force. So if you got a high waistline, you got all those metabolic disturbance and those cardiovascular outcome that is the results of the obesity and increased waistline. So what happened is if you are eating too much or you have too much calorie, those calorie goes in uh, organ that usually don't incorporate fat. So first thing first, all the fat goes into the subcutaneous depot, and then they go into the visceral depot. And if they go into the visceral depot, you got inflammation and you got all those cytokine that are bad for your health. And if you got too many calorie and your subcutaneous depot is full of fat storage and your visceral fat depot is full of fat storage, then you go into the liver, you go into the muscle, the heart, and the pancreas. So this is the main problem. If you got too many calories, the fat goes from sub-Q to visceral depot. So now we're switching gears from a metabolic point of view to a structure point of view. So if you look at the the obesity cardiomyopathy, it was described in 1880 by Shane and Stroke. It was documented as a fatty heart. It was an autopsy study, and then you see the first description of adipositas cordis in the literature. So the normal distribution of adipose tissue, there's adipose tissue in the pericardium. There's adipose tissue in the around the heart in terms of protection. So it's under the epicardium, around the groove where the epicardial vessel goes, and it's the wall thickness. It's a protection just in front, but because as you know, the right ventricle is in front. It's just beneath the sternum, and it's kind of a fat pad that protects from trauma, right? So the problem is if you got too much fat, you got fat infiltration of the myocardium, that more prevalent in women than men. It's 3% in autopsy studies, more in the right ventricle to the left ventricle. It's the anterior wall and the posterior wall, and it's the area of surrounded by fibrosis, not attached to pericardial fat. So this is cardiomyopathy of obesity. So the adaptation of obesity in terms of cardiovascular disease, you got increased interstitial fluid, increased vasodilatation. So at first, those patients are not hypertensive because they vasodilate to accommodate the increased fluid, but this accommodation got limitation. So now when you got peripheral resistance and increase, then those patients become hypertensive, and you got left ventricular filling pressure. So that's why they're short of breath, and you got increased cardiac output. The increased cardiac output and the increased cardiac work is 25% increase explained by the fat and 75% increased by the lean tissue. Because usually when you are heavier because of fat, the lean tissue increase also. That's why when you go into the diet, first you decrease your fluid, so you lose a lot of weight in the first few weeks. It's water, and then you decrease fat mass and lean mass. So 75% of the cardiac output is explained by lean mass. And fat tissue is producing a lot of cytokine, a lot of growth factor, a lot of hormones that impact the vascular wall and impact all the body in terms of inflammation. So if you look at other factors in the pathogenesis of coronary artery disease, you know, obesity is associated with endothelial dysfunction. Why is that? Because of the increased free fatty acid load. It's also associated with increased oxidative stress, and the maximum density of macrophage in lesion, in coronary lesion, is associated with visceral fat, and also insulin resistant and visceral fat is associated with decreased coronary reserve. So the capacity to vasodilate is decreased, and the capacity to incorporate macrophage and increase atherosclerosis plaque is increased with obesity. So what are the cardiac abnormalities seen in obesity? Left diastolic dysfunction, left ventricular hypertrophy. First is concentric, and it's after a while, in terms of years, it's eccentric. You got right ventricular hypertrophy because you got pulmonary hypertension. Could be from recurrent pulmonary embolism, could be from high volume, could be from sleep apnea, could be from everything that will decrease the pulmonary adaptation. You got autonomic dysfunction, so you got decreased parasympathetic drive, increased sympathetic drive. You got arrhythmia, we'll talk to it in a little while. Increased QTC, so there are increase of sudden death, and at the end of the day, you got increased obesity, cardiomyopathy, so increased adipocytosis carditis. So obesity and right heart failure, the first determinant of right heart failure is left heart failure, but you got pulmonary impairment that could impair the right heart, so increase the workload because of sleep apnea, because of restrictive lung disease, because of obesity, pulmonary embolism that are so often without any symptoms. Those patients are hypoxic and hypercapnic, so you got upper pulmonary hypertension, and at the end, you got right heart failure. So this is a schematic that we published some years ago now, and you see the heart failure, and it involved all the mechanism that I just explained to you guys. ECG in obesity, there's a displacement of the heart because of the elevated diaphragm. It's the same as being pregnant in the third trimester. If you pregnant in the third trimester, the baby elevated the diaphragm, so the heart change. And when you put your electrode, because you've got some bone placement, very precise bone placement, but the heart change because of the diaphragm. So because of the increased workload and associated with hypertrophy and increased distance from the heart and the electrode, you got ECG that has micro voltage with micro voltage, and LVH is difficult to see as the same as left atrial dilation. And because you got associated chronic lung disease secondary to sleep apnea or hypoventilation syndrome, all the ECG change is often misled because they're missing. If you look at the insurance of sudden death, if I want to sell to you that obese patients are increased risk, yes, they are increased risk compared to general population. But the risk compared to our patient, day-to-day patient, cardiac arrest or VF or VT survivor is it's not comparable. But still, those patients are at increased risk of sudden death. And the ECG change found in obesity are multiple. Those are less clinically significant, but upstairs, the increase in heart rate, the increase of QRS, QTCs, and false positive for inferior heart attack, those are found often in obesity. And if you want to correct for the false positive for inferior heart attack, just take your ECG while your patient is is doing a high inspiration, and keep that inspiration. So the diaphragm, lowered, and with the diaphragm lowered, then the heart is placing properly, and then sometimes the false positive for inferior heart attack is no longer there. So arrhythmia, obesity is associated with atrial fibrillation. You got all those very fancy late potential that we use sometimes to try to look at the risk of sudden death. And this is very is there in obesity, and it's independent of present hypertension and diabetes. And it could be arrhythmia, could be facilitated by myocyte hypertrophy, abnormal cardiac variability, increased sympathetic drive, decreased parasympathetic drive, focal misalignment of myocardial fiber, fibrosis, fat, and mononuclear infiltration. So this associated with cardiac, obesity, cardiomyopathy is associated with arrhythmias. So if you look at obesity and arrhythmia, Hippocrates say, in the 4th century before Christ, that sudden death is more frequent in those who are naturally fat than those who are lean. So clearly, obesity increased the risk of sudden death and atrial fibrillation in patients. So it's an independent contributor to cardiac remodeling, and when patients lose weight, especially with bariatric surgery, you got better cardiac remodeling and AF decrease, and AF burden also decrease after bariatric surgery. So if you look at the cardiovascular and systemic effect of obesities, when I talk obesity, it's not a typo here, because obesities, there are different obesities. Those are the one with, are increased because of BMI, but not increased because of the waistline, and the one increased with the waistline. So you got all those cardiac abnormality ears, vascular problem here, metabolic problem here, and inflammation, and all those things that we've seen every day. And, during COVID, being obese was associated with a worse outcome. And at the end of the day, you got increased mortality, increased coronary disease, increased heart failure. And if you look at patient who you replace valve, you got the aortic stenosis, you put a bioprothesis in the aortic place, and metabolic syndrome predict the deterioration of the aortic valve. So here, from an arrhythmic point of view, all those features are associated with increased sudden death, and all those features here are associated with atrial fibrillation, and risk factor for obesity is all in there. And you see that obesity impact all the cardiac structure and the cardiac function. So what are the evidence-based management for obesity? First thing first, diet, exercise, and behavioral modification. I hate the word diet because all diets works. It works short term, and people, usually very obese patient, when I saw those patients before bariatric surgery consult, they have tried everything. So they know about diet. But the thing is, they don't know about satiety. They don't know about little things that need to be changed, and it's mostly behavior. The other thing that we need to not say out loud, but to do only exercise to decrease weight is a failure. Because if you run a marathon, you will probably spend 2,000 kilocalories during your marathon. So if you drink 2 Pepsi and a Big Mac, now it's done. From a calorie equivalent. So the thing is, it's a package. Okay, you need to exercise to keep your lean weight, because you're going to lose lean weight if you diet, no matter what. Okay, so exercise is good because it's increasing your metabolic rate during your do exercise, so it's important, but it's a package. So exercise is one thing, and in very obese patient, exercise is a struggle because of the mechanical constraint. So we need to be aware of that. So this is a slide that we published with GP Desprez last year about the aggressivity of intervention and the treatment of obesity. You got here bariatric surgery. You got all those, I would say, gadget that they are putting into the market to try to tackle obesity, and you got here diet and exercise. So, you know, gadget, you got the ban. A few years ago, we got the gastric ban, and everybody was pretty excited about that. Nobody puts bans nowadays. So, you know, and there was some gastric pacemaker. I went to a meeting and I went back to the electrophysiologist here, and I said to those guys, you know what, you're gonna put gastric pacemaker to my patient to lose weight because you increase stomach motility, and then your hormone will be released, and then the hormone will give a feedback to the brain, and people will say we are not hungry anymore. Doesn't work. Okay, but they try, because you know what? If half of the population of US is obese, you can comprehend easily how big market from a pharmaceutical company or technically oriented company is in terms of market. So it's pretty important market. First thing first, patient needs to know your prescription, needs to know, need to be clear, may be clear for you, but it's not clear for patient. Okay. Usually I ask if they got a cell phone. If they got the cell phone, they probably have this apps in their cell phone that counts steps. So I said, you know what? Count your steps for a week, no extra, and then we start from there, and increase 1,000 steps a day per week, and then to try to reach 10,000 steps, because usually, our patient walk between 3,000 to 5,000 steps a day. So if you look at the exercise guidelines and they say 30 minutes of exercise most days of the week, 30 minutes of exercise, if you walk, it's 3,000 steps. So you're increasing to 5,000 steps, spontaneous steps, to 8,000 steps. Okay, so you need to be clear about what you prescribe. Same with nutrition approach. And you know what? I used to be, I'm trained kinesiologist. Okay, so I've got a bachelor in kinesiology, and I turned back. I went into cardiology. But if it would be simple to prescribe exercise or to talk about diet, it would have take it would you know it would have take 3 years to be a bachelor degree in kinesiologist or be a bachelor degree in nutrition. So we need to use those very competent people to help us with our patient. So this is and this is for you to use, okay? Because my slide will be there, but this is all the target, that people are looking for as anti-obesity drugs. So they're trying to find a way to fight obesity with drugs. We can be for that, we can be against that, but we're faced with the problem. So, we need to at least address the problem. So what are the pharmaceutical and surgical therapies for obesity? The indication, I won't talk about drug. If you want to talk about drug, we can do it in the question period. So people unable to lose weight or sustain weight loss with comprehensive lifestyle intervention. The presentation before me, those people were really nice in terms of following up for smoking cessation. It took, if you look at the literature, it took usually 8 to 10 intervention within a year for people to keep weight loss. 8 to 10 intervention. I'm not taking physician. I'm taking multidisciplinary people. So couple from nutritionist, couple from a kinesiologist, couple from a nurse, 1 or 2 from a MD, you got your 8. Okay? The thing is, we need to have the same message. So the mechanism of action of drugs: suppress appetite, increase early satiety, block absorption of dietary fat. So pharmacological therapy may be appropriate for those with BMI above 37 with comorbidity of those with BMI above 30. If you look at bariatric surgery, all those are the techniques used. Sleeve gastrectomy is the one that are mostly used. So surgical procedure to modify GI anatomy to result in weight loss or metabolic benefit. Several procedures available. You see those there. So what are the indication? Bariatric surgery is considered an appropriate option for patients with BMI above 40 or above 35 with serious comorbid condition. The efficacy of bariatric surgery, significant improvement in RCT, so randomized clinical trial, in terms of weight loss, in terms of blood pressure, in terms of lipid, remission of diabetes, but we don't have any RCT in terms of AFib, mortality, CVD event. All those improvement are through observational study. We need a randomized trial, and it's ongoing right now. So at the end of the day, what are the benefits of weight loss? I'm not saying that weight loss is the best thing since sliced bread for the heart, but yes, I would say that it probably is. An decreased blood volume, decreased ejection volume, decreased cardiac output, decreased filling pressure, decreased left ventricular mass, improved left ventricular diastolic pressure dysfunction, improvement of left systolic dysfunction, decreased resting heart rate, decreased QTc interval, increased RR variability. We have, and we published that also. There was some severely obese patient with very bad heart. They were listed for heart transplant, and they went for bariatric surgery, and their heart healed. So it happened. Mayo Clinic published their cohort, and all those cohorts have been seen through the world. So in brief, obesity is a chronic disease associated with many concurrent conditions, is costly and affect everyone, is a complex disease with several factors, difference between energy intake and energy expenditure, environment, genetic and hormone. These factors influence the evolution of obesity and the physiological response to weight loss. It's not easy to lose and even less easy to maintain the lost weight. So with that, I thank you very much for your patience. Thank you very much for hanging there, and I will take some questions if need be. Thank you very much. Sorry for the accent. I'm rusty. Any question?
Elena's just looking for some questions in the chat there.
There's no questions yet, so you can go
Do you
ahead.
have one? Nope. Is mic on? I mean, he can hear. Can you hear me, Dr. Poirier? Yes?
Yes.
Okay, good. It's Kim, and I just wondered, you talked about all the disciplines to help manage obesity. How are you specifically managing in your clinic with your patients? Are you treating obesity as part of your practice, or do you work with a team? Resources are so limited for people living with obesity. I just wondered how you're dealing with it in your practice.
Yeah, so I'm probably, I've got this very, is very model that you have in our heart, because I've got all the nurses and the nutritionists and the kinesiologists. I don't have any psychologists. For me, that's a failure. Okay, so we need to have a psychologist, because this psychologist will help us for smoking cessation, for obesity, for pre-transplant, all those kind of things. So this is in our very high standardized clinic, but this is not the real life. So in real life, we are stuck with, and I've been managing diabetes and obesity for several, I'm getting old, Kimberly, but it's been 45 years now. I'm still 15, so that's fine. But the thing is, if you look at the outpatient clinic, first thing first, I want to have the weight that the patient have at the prom. Okay, women Remember that for sure because they want to get into their dress, but men are pretty good. Or I want to know the weight at their first marriage, not the last one because I've been screwed before. Okay. So, people, those people try it, right? So if, for example, the weight is 140 for a man at, at the end of the secondary school, okay, high school, and now he's 220. First thing first, I say to the guy, you won't weight 140 anymore. Forget about it. Okay. So, and if he's 60 years old and he was at 140 at 20 years old, I said, you know what? It take you 40 years to put on 80 pounds, which is a miscalculation. And I said it out of front. It's a miscalculation. But just for them to know that it's a long process to put on weight, and it will be a long process to lose weight. So my name is Poirier. So in French, you cut the pear in half. So I said, you put on 80 pounds. So let's go for 40 pounds. So 40 pounds is 220. So, and usually people, when they're realistic and ask, what where do your expectation? And this half is usually the same. So I said, okay, 40 pounds. Okay, let's say there's 52 weeks in a year. So if you want to lose half a pound or a pound per week, it will take you at least a year or two. Okay, so people will not get discouraged because those people lose weight. And I send them to the nutritionist. And they say, I don't have any insurance. That's fine. Because if they don't have any insurance, they can, because I've prescribed a nutritionist, they can put that on their tax at the end of the year. Okay. And then and then the nutritionist will say to me, how we can go, and the nutritionist will do follow up. This is for diet in the outpatient clinic without all those very fancy multidisciplinary approach. For exercise, that's the same. You say, you know what? You need to reach 10,000 steps a day. We need to fight the sedentary behavior. Okay. So I said, increase 1,000 steps a day per week or per 2 weeks to reach 10,000 steps a day. And if you reach 12,000 steps a day, you're not allowed the next day to have 8,000 steps a day. It's a 2,000 step bonus. And I say to them, when you go to sleep and you didn't reach the 10,000 steps a day in that day, feel cheap kind of. Okay, because I want them to change their behavior. And they say, you know what? They're talking about miles or kilometers. Doesn't make sense. Okay, because if I've got a 5 feet tall woman with a guy of 6 feet tall guy, and they walk the same kilometer, they will not have the same number of steps. So it's a steps oriented, not a distance oriented. And the other thing I say to those guys, if you walk a marathon or you run a marathon, you will lose the same amount of calories because you're going to walk the marathon in 12 hours and you will run it in 4 hours. It's average the same amount of calories. So people knows that those little steps will work. And if I want to work into the fit principle, because they're probably kinesiologists in the room, if you do brisk walking in obese patient, they use 60 to 65% of their VO2 max. So they're just at the anaerobic threshold. So I said to those guys, if you want to walk briskly, fine, 100 steps per minute. So I don't want them to count the 100 steps per minute because they will fall into people. So I said, you know what? When you go to Canadian Tower, it's 10 to 9 and it's going to close. That's 100 steps per minute. So I give some example in the day-to-day, and I try not to use elevator or use mobile escalator.
There's a
Hello?
question in the chat. With the evidence that 95% of people who lose weight regain it, many nutrition professionals have been promoting health at every size. What do you think of this approach? Another experts have said to just not gain further weight.
I'm against that. Totally. Okay? Because healthy weight, if you got excess weight, okay, it's okay, you can be metabolically healthy, no diabetes, no dyslipidemia, no hypertension. That's fine. But what about your knees and your ankle and your osteoarthritis? There's no way the human could be overweight or obese and be medically healthy. I'm not saying metabolically healthy, I'm saying medically healthy. And for me, and I'm sorry, but it's a loser approach. You know, in life, you can have results or excuse. You cannot have both. But I'm sorry, and I know people will say, he's crazy, he's a cardiologist, blah, 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 blah. Been there, done that. A cat, you need to call it a cat.
Another person asked, would you ever prescribe a medication that has a 95% failure rate?
Oh, yeah? Sure. You know, I've tried everything in patients that are desperate. Okay? So the thing is, I will use that to change behavior. You know, quite frankly, Elena, quite frankly, at birth, do you have hypertension? Do you have diabetes? Do you have obesity? No, you become. Why is that? Because of your choice. So we need to make that choice easier to do. That's the main thing. You know, there's maybe dietitian in the room. People will say, okay, the starvation diet, 12 hours, 16 hours. But ask the people if they eat. They don't eat that much usually. Do they eat at night? Yes. Why? Just ask that question. I think it's a behavior thing, I think.
Are there any other questions?
Have you had any success with any of the medications?
Yeah.
Yes.
Yeah.
You haven't really spoken to medications at all.
Yeah, I use, it depends if my patient is hungry or not, and if he's diabetes or not. So if he's got diabetes and he's hungry, I will use a GLP-1 agonist because he's hungry. If he's not hungry, by the way I assess things, I will use SGLT2. This is for diabetes because in Quebec it's covered. And in Quebec, if he's obese, I would say if he's on insurance or not, and then it will change my the way I see things. I usually use liraglutide once a day because it's easier for me to modulate. Because some people takes their shot in the morning, but they still hungry at night. So I will ask them to use their sub-Q shots in the afternoon to cover the night. And then if I got a nice weight loss and people got satiety and they lose weight and they're pretty enthusiastic about their losing weight, then I will change for once a week. But the once daily is I think in my practice is easily to manage because people got birthday, it's Christmas time arriving, they want to have some fun with friends, right? And go to restaurant. And if they cannot eat because they enjoy eating, then you just forget their shots.
And there's
And,
another. Oh, sorry, go ahead.
yeah, and I don't know the exact name, but the drugs that we use for deficit disorder. So if my patient got deficit disorder, I would, and he's bulimic, I will use Vyvanse. I don't know the exact word, the equivalent in terms of the generic name. So I use kind of everything. Or I will use Wellbutrin and naltrexone separately if my patient doesn't have any insurance, so it's less costly. It's not the exact same dosage, but the thing is, I need to have a feeling of success in my patient and a need of trust with me. And when I got that, then it's easier to manage. I sounds harsh, the last five comments. But the first thing first, those patients are running from failure to failure to failure to failure. They're desperate. So, and they need quick fix. There's no quick fix.
There's another question in the comments from Cheryl asking, do you apply waist circumference and height in your practice, or are you still using BMI?
No, BMI, no, I'm not using BMI for the last 15 years. It's waist circumference. Because the obesity paradox, it's all about BMI.
Mhm.
But if you look at the waist circumference, the obesity paradox does not exist.
No further questions. Thank you so much, Paul or Dr. Poirier. It was such a great presentation.
Thank you. Take care.
So we're a little ahead still. Yeah, we'll go for a break now. Our next presentation will be at 1. Starting now, the post-event quiz should be open, and that will be closing around 3:45, and we'll do some more draws at the end of the day. So we'll meet back up for round 1.